It's lovely to be here and to talk about this subject, which is such a controversial and important subject. The subject I'm going to talk about is puberty blockers for children. Can they consent? And before I go into the details of this, it's important for all of us to realize we're talking about actual children, individuals who are vulnerable and in many cases very distressed. So keeping that in mind. And the other thing is you'll see a lot of references in this talk. So you can ignore those if you like, if there's a list of them at the end, and if anyone actually wants that list, that's absolutely fine. So puberty blockers for children, can they consent? First of all, it's worth getting some sort of definition of what is gender dysphoria. Is this mic working okay, guys? Yep, good. The DSM-5, which is one of the main classifications for diseases, calls it a marked incongruence between one's experienced or expressed gender and your assigned gender lasting at least 6 months. When they say assigned gender, it's probably better to say assigned sex at birth. I think that means a bit more. We're not here including the rarer cases of what is sometimes called intersex. For example, people who are born with an X and Y chromosome that doesn't match their physical characteristics. These people need a particular care and compassion. What has always been the case? Well, a proportion of boys will naturally have more feminine characteristics than others, and a proportion of girls will naturally have more masculine characteristics than others. And in fact, for the girls and the boys, you get a sort of bell curve distribution for each of them. So at one extreme, you'll have boys that are a bit more feminine, and at the other extreme, you'll have girls who are a bit more masculine, at least for a while. It used to be called tomboys. I'm not sure if that's still the right term. This is not the same as gender dysphoria. But of course, such people may be vulnerable to being influenced by the current politics of gender. In 2013, gender dysphoria in natal males, that's biological males, was considered to be 5 to 15 per 10,000. Amongst natal females, 2 to 3 per 10,000. So you see there, back in 2013, that the numbers of females are actually considerably less. So that's an important thing to take on board. Just 2013. Welcome everybody who's coming in just now. Hopefully there's enough seats. There's more seats over here. So we'll just pause for a moment. No problem. So, this is an important, this is done by the American Psychiatric Association. It's reasonably reliable. This is in America. So you're seeing there that the gender dysphoria in females was considerably less than in males. And yet, in 2017, 1.8% of high school children in the USA that year identified as transgender. And I think in the UK you might get something similar now. And this is at least 100 times the prevalence stated in 2013. So something extraordinary is happening. And this is reflected in the referrals to the London Tavistock Gender Identity Development Service, Tavistock GIDS, which is the main clinic that deals with these cases in England. You can see here from 2009 to 2019 a very steep increase in the numbers, and you'll also see that the natal females much more than males. And what is happening is seen by many people is a form of gender dysphoria that is very rapid in onset. So you're finding that young girls more than boys, with no previous evidence of this, are suddenly stating that they want to change their gender. Now, Lisa Littman did a study in 2018. She got volunteer parents through 3 websites about gender dysphoria. And specifically, she asked for parents who had children with gender dysphoria that had been expressed suddenly during or after puberty to complete this 90-question survey, and she obtained 256 responses, and they are very illuminating. 41% had expressed non-heterosexual orientation before identifying with gender dysphoria. That's a very significant percentage, and we have to then ask ourselves, why should that be? Why are people with same-sex attraction wanting to change their gender? 62.5% had a diagnosis of at least one mental health disorder or neurodevelopmental disorder, such as autism, before the onset of gender dysphoria. 82.8% were natal females. 36.8% had friendship groups in which the majority had identified as transgender. Now, this is an important fact as well. What is the influence of peers on these young people? 47.2% had a decline in mental health after expressing gender dysphoria, according to these parents at least. And 57.3% had a decline in parent-child relationship after expressing gender dysphoria. And probably Stella will say a bit more about this, the tensions within families when a child suddenly expresses gender dysphoria can be very, very intense and cause a great deal of stress and difficulties for the parents, particularly if the parents are very doubtful about it, but then they are told by certain people that, well, they might commit suicide if they don't go ahead with medical treatment. 25% stopped spending time with non-transgender friends. 86.7% after expressing gender dysphoria showed an increase in social media or internet use, or belonged to a friendship group in which one or multiple friends had identified as transgender within the same time frame. Hazel Gorman did a study in 2019 of over 48,000 children who had been diagnosed with autistic spectrum disorder, and they were over 4 times as likely to be diagnosed with gender dysphoria compared with matched controls. It's another significant association. Bechard in 2017 did a study of 50 consecutive referrals for gender dysphoria. 80% had some form of prior outpatient assessment for psychosocial or psychological problems. 22% had been inpatients for such psychological problems. We're talking about huge numbers here of, before expressing gender dysphoria, having severe psychosocial issues. 54% had been on psychopharmacological medication. 34% had already dropped out of school. 62% had had suicidal ideation. 36% had self-harm. 20% had a history of physical abuse. And 10% had a history of sexual abuse. This is the background to many of these young people. We need to talk about desistance. What does that mean? If a child with gender dysphoria is followed up without medicalization, sometimes called watchful waiting, or giving support without medicalizing, then desistance is what happens in the majority, according to most surveys and studies. There was a study by Steensma in 2013, 246 children with gender dysphoria without medical treatment. At the time of follow-up later on, 84.2% had desisted. In other words, they had become comfortable at least with their biological sex. Ken Zucker, one of the main researchers in this area, said if one peruses carefully the follow-up of young children with gender dysphoria, the majority of such children do not have gender dysphoria when followed up in adolescence or adulthood. Study by Singh published in 2021, a study of 139 boys with gender dysphoria who did not have medical treatment follow-up showed that 79.8% desisted. We need more information, more studies on these things, particularly on the rapid onset type, to see. It's very difficult though, because many will go to the gender clinics. They will already have started on puberty blockers. So, and then we have to think about, of course, the effect of medicalizing a child or their condition on desistance. Theoretically, at least, blocking the puberty will likely prevent the role of hormonal changes in the usual pattern of desistance. And just medicalizing the dysphoria itself and affirming it may itself reduce the desistance rate. Now, is this acceptance, the increased numbers, I should say, is this due to just social acceptance and availability of clinics, one might ask? Well, the recent increase in gender dysphoria is almost confined to children approaching puberty and adolescence, and is usually rapid in onset. We would expect other age groups to be also presenting in greatly increased numbers if acceptability and access to help was the reason. Is it a new phenomenon? Well, a decade ago, most gender dysphoria in children presented in early childhood, not as we're beginning to see much more around about puberty. The vast majority of new onset gender dysphoria occurs in girls, and as we've already said before, the previous data showed that it was more common in boys. So we are seeing a new form of gender dysphoria. This increase in girls also parallels the considerable increase in anorexia nervosa in girls over the past decades and in self-harm among girls, suggesting at least a common underlying cause. And we have to look at what's called social and peer contagion. These are academic terms. Social contagion, this is a quote, is the spread of ideas, feelings, and some think neuroses through a community or group by suggestion, gossip, or imitation. Here's another quote. Peer contagion is evidence suggests that children's interactions with peers are tied to increases in aggression in early and middle childhood and amplification of problem behaviors such as drug use, delinquency, and violence in early to late adolescence. Social network analysis suggests that peer contagion underlies the influence of friendship on obesity, unhealthy body images, and expectations. So we're not proving anything here, but we are at least considering what is a well-known phenomenon of peer and social contagion as a possible effect. And then, of course, there's plenty of books and information that's out there. If you go into Waterstones, you'll probably find a lot of these books, which are at least making acceptable and perhaps encouraging people who are distressed into becoming gender dysphoric, or at least having a great feeling that they are in the wrong gender. Some of you will have come across the genderbread, I was going to say gingerbread, genderbread person. This is a way of trying to show that unlike biological sex, which we normally consider to be a very fixed thing, gender is a fluid thing. It's what you feel. So that's another expression that will be exposed, children will be exposed to. So let's get down to puberty blockers, otherwise known as gonadotrophin-releasing hormone agonists. They block the physiological production of sex hormones, that is testosterone in males and estrogen in females, and they're responsible for the changes that occur in puberty. They are otherwise used for chemical castration for particularly sex offenders, and in rare cases of precocious puberty, which is a completely different phenomenon where a child gets puberty very, very early. Now, puberty blockers postpone the changes of puberty, and the idea is to decide if transition goes ahead. The idea in the clinics who prescribe this is that the child will have an opportunity to think about it for going to full transition. And they are said to be reversible. We're going to talk about that. In fact, many of them will already have socially transitioned, and that is, they'll have changed their name, they'll use different pronouns, and possibly dressed differently. Now, the clinics, certainly the Western world, mostly follow what's called the Dutch protocol, which was developed some years ago in the Netherlands. We're going to talk a bit more about that later. At what's called Tanner stage 2 of puberty, which is the early stages of puberty, and from the age of 12. So what are some of the side effects that we at least know about from puberty blockers? First of all, bone density. There is a significant reduction in expected bone density by the age of 22, some even at the osteoporosis level. Brain development. Well, we know that sex hormones are essential for normal brain growth. In fact, the brain has sex-specific receptors for estrogens and androgens throughout the brain. So stopping this effect at a very crucial time of brain development, which continues to the mid-20s at least, is theoretically at least something very much to worry about. In fact, a paper that came out this year used puberty blockers on monkeys, and the overall conclusion was the effects of the experimental delay in brain development were broad and profound. So it's very serious. And what I would call the inevitable trajectory of taking puberty blockers, at least in the clinics, Tavistock Kids, and I would say the Sandyford in Glasgow as well. This is from the GIDS clinic, the data that they've given. 98% of patients taking puberty blockers at Tavistock Kids progressed to taking cross-sex hormones. That's testosterone and estrogen, which, as we know, have irreversible effects. So what are the irreversible effects of this trajectory of puberty blockers to cross-sex hormones? First of all, we've already discussed low bone density. There's brain development delay. Infertility. A high proportion who go through this process will be infertile permanently. I don't have the exact numbers, but it is a very significant number. Impaired sexual function. Many of them will never have normal sex lives. Obviously, with testosterone, deepening of the voice, male hair pattern. We also know that if you take estrogens, you're increased likelihood of strokes, blood clots, heart attacks for those who take estrogens. Then many will go on to surgical procedures, double mastectomy, genital surgery. Some get hysterectomy and oophorectomy, that's removal of the ovaries. What about the psychological effects of taking puberty blockers? Well, they're given often with the promise of alleviating the distress. So we need to know whether it actually does that. The Dutch study back in 2014, De Vries et al., looked at 70 individuals. They reckoned there was some short-term improvement in depressive symptoms. In fact, we don't know about the long term, and I know from that study there was no improvement in anxiety, for instance. The outcomes were only done on 55 of the 70, and they omitted the non-completers. Some measures were only on 32 of them. This is a very flawed study, you can see. Of the 15 not included that did not complete the course, 3 developed morbidity stopping them, 2 refused to continue, and 1 died from post-surgical sepsis after genital surgery. This Dutch study remains the strongest clinical evidence for use of puberty blockers, and is still held up as the main research that the clinics base their work on. Tavistock Kids eventually, after some pressure, produced a paper in 2021. 44 individuals on puberty blockers were studied, small number, At 6 to 15 months, only 49% had a mood improvement, 24% had negative mood changes. Then later on, 15 to 24 months, less than 30% had mood improved, and 29% had negative mood. And they admitted, we found no evidence of change in psychological function or of self-harm. But if you look at the data, it's actually a considerable number had worse psychological function. Turban, this is a paper that's quoted a great deal on the risk of suicidal ideation in those getting puberty blockers, concluded that suicide was reduced. This is one of the main papers that is held up as promoting the use of puberty blockers and reducing suicide. But it's an incredibly flawed paper. There was an online survey offering cash prizes. The people were recruited through transgender organizations. You can already see the bias there. Detransitioners were not included, extraordinarily. And 73% said they began the puberty blockers after the age of 18, which is very unlikely. That's not when you take the puberty blockers. The only systematic reviews and meta-analysis, as far as I know, that have been done are by the National Institute for Clinical Excellence in the UK, that's NICE, and the national health authorities in Finland and Sweden, and all three countries are calling a halt to the immediate affirmative care for minors with gender dysphoria. There's a complete, in England and Wales at least, there's a complete review, which we're going to talk about. And yet this is a quote from Mermaids, one of the main trans lobby groups for kids with gender dysphoria, from their website in 2020. Hormone blockers have been widely researched for 3 decades. It's an internationally recognized treatment which has had hugely positive impact on many young trans people. Nothing negative, no warnings, that's all that's put out. Now, many of you will recognize Kira Bell. There's a picture of her. Kira Bell went through the Tavistock GIDS clinic. She had, I think, a short-term puberty blockers. She then went on to cross-sex hormones. She had a mastectomy, double mastectomy. And then when she was 20, I think Stella will probably know, around about 20, she realized that she'd made a mistake, that her brain was maturing. She felt that she actually was a girl, despite having wanted to come out as a boy. She also had very severe psychosocial issues when she went to the Tavistock GIDS clinic, and she's very open about this, and you can go onto her website, and she's got a long essay really about that, an interview. So she bravely went to the court and brought the Tavistock GIDS clinic to a judicial review in 2020. Many of you will have followed that. And the ruling, which is well worth reading by those judges, it's a very detailed, carefully argued ruling, said that it is highly unlikely that a child under the age of 16 could be competent to give consent to puberty blockers. Now, it's worth talking about what's called Gillick competence. This is from a House of Lords ruling in 1986, and it covers the competence of young people to be able to give consent. So it's about the right of a child under 16 to consent to any medical treatment if a clinician believes they have enough maturity and intelligence. And you have to assess a child for this. I mean, GPs do this all the time. If somebody comes in age 13 and is asking for a particular treatment, it might be oral contraceptives, something like that. You need to know the experiences, their ability to manage influences on decision making, such as information, peer pressure, family pressure. You have to take account of their understanding, their ability to weigh risk and benefit, consideration of long-term factors. That's key. Long-term factors in taking puberty blockers. Can a child age 12 consider infertility or loss of sexual function? And of course, you can be Gillick competent for one treatment, but not for another one. Now, looking at the adolescent brain, it matures well into the 20s. It's a well-known fact. And it's worth mentioning the Gender Recognition Reform Bill in Scotland, which has been passed by the Parliament here, which reduces to the age of 16 the ability to get a gender recognition certificate. Consider that when we're talking about the ability of the brain to make decisions about gender. And we know that teen behavior across all cultures involves increased novelty seeking, increased risk taking, social affiliation shift towards peer-based interactions. Remember the title of this talk is, Are They Able to Give Consent? And in the Bell v. Tavistock case, GIDS could give no evidence of ever considering a child to be incompetent. And judgment is worth reading there. The approach appears to be to continue to give the child more information and to have more discussions until she or he is considered to be Gillick competent or discharged. That's the judge's summary. Bernadette Wren was the Associate Director of GIDS in 2015, and she spoke at the Parliamentary Women and Equalities Committee. She said this: I work in a service where a lot of young people, and anyone who wants it, can have physical intervention. We have no record of turning people down for physical intervention. So you're seeing there very blatantly the affirmation model. There was a Court of Appeal case brought by the Tavistock to refute the original case, which they won. And the judge said it is for doctors, not judges, to decide on the capacity of under 16 to consent to medical treatment. So we're back to square one. And yet how is it that clinicians at the Tavistock and elsewhere didn't even record one case of Gillick incompetence over many years? We then have the CAS review. This is a review which is the NHS has asked Dr. Hilary Cass, a paediatrician, to undertake into the whole of the gender services for children. And she produced an interim report last year which said that the current practice is unsafe and the Tavistock GIDS is in the process of being closed down. The Sandyford Clinic in Glasgow have not really commented on this. I don't have any further information except to say that they are continuing on the same practices. We then have the case of detransitioners. These are people like Kira Bell who have gone through the whole process of medicalization and transitioning, and then often in their 20s will decide that they actually have made a terrible mistake. And we're seeing increasing numbers. We need more research on this. We don't know the numbers, but there really are. I've met some of them. I know Stella has met many. They have irreversible and deeply regretted changes to their bodies, and their stories are pretty heartrending. And there is great lack of support for these people. What is the NHS doing about it? The clinics, in general, take them off their books. So facts to help us to know if children can consent to puberty blockers. Just going over a little bit, and this, I'm nearly finished. There's a lot of information here. There is a new form of rapid onset gender dysphoria. Gender dysphoria is strongly linked to pre-existing social and psychological pathology and autism. And I've already mentioned same-sex attraction as well. Gender dysphoria is strongly associated with social peer contagion, paralleling anorexia nervosa and self-harm. Gender dysphoria naturally desists in the majority. That's the evidence we have so far. The brain is immature until at least the mid-20s. Sex hormones are required for brain maturation. Should we be stopping them at a very crucial time for that? And a child really, certainly in my opinion, cannot understand the long-term implications of, for instance, lifelong infertility, loss of sexual function, and the irreversible other changes associated with medicalization. And there is absence of an evidence base for the use of puberty blockers in gender dysphoria. They lead on to irreversible effects of cross-sex hormones and often to surgery. And we've seen detransitioners more and more. They are traumatized and they have deep regret. They need all our support. Well, my conclusion is that children cannot consent to being treated with puberty blockers for gender dysphoria. With the current knowledge that we have, we really need not to cause harm. That's what clinicians, it's a maxim which we really have to hold on to. We should not be causing harm to people. And the evidence is that we are causing harm. So there's a lot of references there. They're all in a list here. If anyone ever wants them, that's fine. Thank you very much.